Well, good afternoon. I can see that it's starting to thin out a little bit, so you guys are the diehards, right? Well, I titled my talk, Mood and Motivation in Parkinson's Disease, How to Get the Upper Hand, because we are in the middle of spring training, and actually that metaphor is a good one for mood and motivation, kind of the sandlot determination of who gets to bat first. But let's start with the question of why is it important to look at mood and motivation? Why are these changes important to look at and to consider? Well, one is that they significantly relate in studies to patients' quality of life. In fact, factors related to mood and motivation are considered more important to quality of life than actual motor disturbances that are associated with Parkinson's disease. Another aspect is that these are some of the difficulties that contribute most to caregiver distress, to spouse and families, and even over and above motor symptoms. Now, we have classically thought of Parkinson's disease as a movement disorder for many years, and now there's increased interest in many non-motor symptoms. And the focus has really come from the patients who've told us that these are some of the symptoms that are some of the most difficult to overcome. Another reason that mood and motivation are important is that they do seem to relate to disease progression. So increased mood disturbance, decreased motivation are associated with a faster rate of disease progression. And lastly, these are difficulties that are treatable but often unrecognized or unreported. I'm going to talk today about two symptoms in Parkinson's disease, one mood-related, one motivation-related. The mood-related symptom that I'm going to talk about is depression, and obviously most of you are aware that depression occurs with a high rate of frequency in Parkinson's disease. But another new kid on the block, but actually has been around for quite some time, is apathy. And this is turning out to be actually a symptom that may be even more impactful than depression. Let's start with depression. I'll talk more about apathy in a moment, but let's start with depression. What are some myths about depression? And this is not just in Parkinson's disease, but depression in general. Depression isn't serious. What's really serious is my Parkinson's. That needs to be treated. I need to be able to get that under control. But depression can be very serious. It can be very disabling. It can really strip someone of their joy for living. So it is something that, if persisting, is important to pay attention to. Another misconception is that depression is a weakness or a moral failing of some sort, and this couldn't be farther from the truth. Depression is a combination of environmental and biochemical changes that occur in an individual. They may be short-lived, they may be long-lived, but they're certainly not a weakness of the individual or a moral failing. And I think this is probably the biggest obstacle for people to overcome. Probably the biggest obstacle in terms of seeking treatment. Another myth, well, I should just toughen up and take it. Life is tough. You got to just roll with the punches. But life isn't intended to be punishment all the time, or hell all the time, or gray all the time. If that's what you're feeling, that's not what life is. That's depression. I'll snap out of it. Well, I'm having a bad spell now, but I'll get over it. I'll snap out of it. But time goes on, and your family member or your friend doesn't snap out of it. It just continues. And this is something to pay attention to. How long do those symptoms last? Do they persist? I'll be like this forever. Nothing could be further from the truth. There are ways to intervene in depression that include both pharmacologic and non-pharmacologic interventions that are successful and have been studied in patients, particularly with Parkinson's disease. Now, I want to make a distinction between depressive symptoms and major depressive disorder. All of us at some point experience depressive symptoms. It's part of our nature. Part of being human is to experience disappointment, is to experience depression. But depression can range from mild to some symptoms of depression that are transient, and we've all had good days and bad days. Sometimes bad days can be really, really bad. And other days, you wake up in the morning and it's like, oh, thank God it's a new day. And your perspective is different. But if your perspective is not different and it persists, then those symptoms become more long-lasting. So there are two dimensions. One is severity, how mild or severe, how many depressive symptoms. The other is how long do those symptoms last? Are they transient? Can you find yourself bouncing back, feeling like your old self? In fact, that's a question that you can ask yourself. When did I feel like my old self? If it feels like a long time since you felt like your old self, then think about what your mood has been like and whether you're experiencing some symptoms of depression. There are formal criteria for a depressive diagnosis, but I think it's really important to keep this continuum in mind. It's not like you're not depressed and then you're depressed. All right? That's kind of a box model, what we call a categorical model. Our thinking nowadays is much more along a continuum, and that people tend to slide along that continuum, okay? Or even be on the cusp of meeting criteria for major depressive disorder. But there are formal criteria, and at least one of these symptoms has to be present in a 2-week period. Either a depressed mood, that is, feeling sad, or a loss of interest or pleasure. So two sides of the same coin, or two sides that actually show different aspects. One is sadness, the other is the inability to experience pleasure. The inability to get from things that you used to enjoy the same pleasure, the same satisfaction, the same appreciation or gratification. Other changes include changes in appetite or weight, too little or too much sleep, fatigue or loss of energy, feelings of guilt or worthlessness, difficulty in thinking or making decisions, or recurrent thoughts of death or suicide. One of the questions is the depression in Parkinson's disease different? Now, if we look at some of the symptoms that we just reviewed, there seems to be an overlap with a lot of the symptoms of depression. So if we look at those items in blue, changes in appetite or weight, frequently seen in Parkinson's. Too little or too much sleep, frequently seen in Parkinson's. Fatigue or loss of energy, definitely seen in Parkinson's. Difficulty thinking or making decisions. So there seems to be a tremendous overlap between the symptoms of depression on the one hand and the symptoms that are associated with Parkinson's. So that really kind of begs the question, is the depression in Parkinson's disease different? Or is it just a reaction to a chronic disease or part of the disease process? Is depression part and parcel of Parkinson's disease? Well, we know that there are higher levels of depression in Parkinson's compared to other medical disorders, even if you control for comparable levels of disability, functional disability. We know that the depression oftentimes predates the motor symptoms. This is referred to as the prodromal phase, the phase that we're more interested in identifying, particularly as therapeutics become more available. And we know that in persons with Parkinson's disease, that in experimental studies, there's a decreased sensitivity to reward conditions. So what does this tell us? This tells us that, in fact, there does seem to be some association of the depression with Parkinson's disease, and that there may be some involvement of overlapping dopaminergic and other systems. Well, irrespective of whether depression is bound up with the Parkinson's or in reaction to having Parkinson's, a really practical question is, how do we treat it? How do we treat the depression in Parkinson's? Well, there are pharmacologic interventions, and there are non-pharmacologic interventions, cognitive interventions, and those are the ones that I'm going to spend more time talking about today. Most of you are aware that the treatment of choice is typically SSRIs for pharmacologic interventions. For cognitive interventions, by far the most significant and effective intervention is cognitive behavior therapy. So why consider cognitive interventions? Why would it be useful to consider them? Well, if you're already on an antidepressant, we know that the response in individuals who are depressed is best if pharmacologic treatment is combined with some sort of cognitive or psychotherapy intervention. Another thing that is really important to underscore is that cognitive therapies in and of themselves result in changes in the brain. All right? The brain is constantly changing, constantly adapting based on your experience. And there's very strong data in over 20 studies now that show that changes in the brain that occur with pharmacologic interventions like SSRIs, that implementation of cognitive therapies results in similar changes, somewhat different, but similar changes in areas comparable to SSRIs. All right? So we need to think of the brain as constantly is dynamic, as changing in response to your experience. You're constantly creating new synapses, new connections, new pathways are strengthened. And you can do that based on your behavior. So you've probably heard of the use it or lose it. And no greater truth could be said. I mean, that's a very simplistic way of saying it, but there is a lot of data to suggest that a mind at rest remains at rest. A body at rest remains at rest. So those who continue to engage cognitively, continue to engage physically, are those individuals who are going to have a more successful outcome. So here I have this image of a person tinkering with a brain, and that's you. Those are things that you can do to strengthen pathways, strengthen automatic connections and thoughts and feelings at the neural level. So what are cognitive interventions? Cognitive interventions are a look at the interaction between our thoughts, our feelings, and our behaviors to better understand the patterns that people get stuck in. And we can get stuck. I'm going to talk about a number of ways in which we can get stuck. And that's all of us, myself included. Another focus of cognitive interventions is to develop new strategies to overcome or cope with a problem. The days of lying on a couch are gone. All right? Most therapies, and cognitive behavior therapy in particular, focuses on the here and now. What are the problems the person is currently experiencing? What are the particular circumstances of that individual? What are the specific difficulties that someone is experiencing right now, today? Not 50 years ago, not 60 years ago, but right now. Cognitive interventions are time limited, and they're focused on teaching skills and new strategies. I was interested to hear during the dance presentation use of the word skill set. And this is a very apt phrase for cognitive interventions. It's about learning skill sets. And it's about learning ways of thinking about problems and coming to solutions. Importantly, the person has to practice those skills. All right? You don't get a return on your investment without making that investment. All right? So it's not quite as passive as taking a medication. It very much involves the individual. The person has to be on board with this. You have to be on board, and you have to want to work. Because getting through some of this and getting through depression is work. So it's developing a toolkit, your own personal toolkit, because each of you is very different in terms of how you respond to negative events. It's having at hand something that you can use actively, where you're the agent of change. You're the person who is affecting that change. I want to make one recommendation, and I have no financial interest in this, no personal interest, nothing. But if some of these ideas appeal to you and you want more information about how to approach this because it sounds so overwhelming, this is a great book. It's called Mind Over Mood. And it is pretty inexpensive. I think it's on Amazon.com. It's like $15, but it's a workbook. And you actually have to sit down and think through some of the places where you get stuck. And what are some of the things that you can do potentially to get yourself unstuck? Depression is a spiral. It starts out by feeling unhappy, then spending more time alone. All right, you get invited to go out, but you withdraw from people. You spend less time socializing, more time alone. Then you start feeling more depressed. You withdraw, become less active. Start feeling more depressed. And it's a downward spiral. To the point sometimes where you feel like it's taken over you, all right? It's no longer about you kind of slipping, it's being pulled, as if you're being pulled into a vortex. And again, that's when depression is really severe. I'm going to talk about cognitive distortions, because that's really the basis for a lot of cognitive behavioral therapies. When something happens to us, we have thoughts about it. Let's say something negative happens to you on the way here. You're driving and someone drifts into your lane and then beeps at you to boot, right? Now that's a believable situation here in Tampa. You have certain thoughts about that, feelings about it, and then maybe some reactions to that. You know, maybe you just say, okay, I'm just going to keep driving, I'm not going to look at this person, or you beat back, or you shoot them a bird, or you yell. I mean, there's a million different ways you could respond, right? Or that you might want to respond. But that first step in the link are thoughts. And what I want to start out with is, don't believe everything you think. That's a little scary, isn't it? If you can't believe what you think. But let me explain what I mean. We have shortcuts, all right? Kind of automatic thoughts that occur to us. And all of us have our kind of select few that get activated automatically when something bad happens to us, something that is distressing. And some of these are distortions that we perpetuate, all right? But they're shortcuts. They're easy, they're automatic, we do them without even thinking. It's that self-talk that gets generated right away. One cognitive distortion is all or none thinking. If something is less than perfect, it's seen as a failure. All right? I haven't been out driving in a long time. I picked this day and this route because I think it's, fairly peaceful, And this happens, and see, I can't drive. All right? It's either perfect or it's horrible. It's either acceptable or it's just completely unacceptable. There's no gray area in between. All right? So that kind of thinking is called all or none thinking. Overgeneralization. View a negative event as a never-ending pattern of negativity, and not even paying attention to things that are evidence to the contrary. So if you find yourself using the words never, always, all, every, none, no one, nobody, everyone, then you might want to consider the possibility that you're engaging in cognitive distortions. And think about, how realistic is that? How realistic is it? Is there another way of thinking about it? Mental filtering, focusing on a single negative detail and dwelling on it until to the exclusion of others, until one's vision of reality is consistent with that dark image. So you go to a dinner party, and you haven't been out as a couple in a long time, and you spill something on your shirt. And that one detail of the whole evening kind of overtakes everything. The evening has now become, that filter is a bias. It's kind of a lens that we look through that distorts that one event. Magnification or minimization. Magnifying the negative on the one hand, but also minimizing the positive. Not paying attention to those things that occur around us that are actually opportunities for having a good experience. And there are a lot of these. There are a lot of these distortions. I'm only going to go through a few more. Emotional reasoning, assuming that my negative feelings necessarily reflect the way that things really are. Because I feel it, it must be true. Not I fell, but I feel useless, therefore I am useless. Are those two logically the same thing? Are there ways that that belief system can be challenged? Rigid rules, having a fixed idea of how you should be or how someone else should be, and again, associated with shoulds or musts. Fortune telling, I like this one. Anticipating that things will turn out badly and feeling convinced that the prediction is an established fact. If we could tell the future, but we can't. But sometimes we convince ourselves that we can and that it will be so. Name calling. Putting an extremely negative label on oneself. I'm a horrible wife. I'm a horrible husband. I'm a failure. I'm useless. And letting those terms dominate. Cognitive interventions like this, like cognitive behavior therapy, are geared towards challenging these automatic thoughts that we have, and we all have them, for good, for better or worse. These types of treatments have already been demonstrated to be effective in Parkinson's patients. In Parkinson's patients with depression. So there are a number of randomized controlled trials of this type of intervention that has shown it to be effective, not just in depression, but in persons with Parkinson's disease and depression. Apathy. That's a bit more tricky, but we know it when we see it, right? So my get up and go just got up and went. Probably at this time of day, everybody's get up and go has gone up and went. So we know it, that kind of bump on a log, lack of initiative, lack of generation, lack of motivation. But what is apathy not? Well, first I'll start with what on the affirmative side. Changes in apathy are characterized by a loss of interest and a loss of initiative. It's distinct from depression and can be dissociated from depression, although there's tremendous overlap. Importantly, it seems to be more associated with some cognitive difficulties than depression. So it may be an important signal to pay attention to. Apathy is not laziness, okay? Apathy is not fatigue. Apathy is not stubbornness. Apathy is not willful intent on the part of the person. It's a lack of initiation of purposeful, goal-directed behavior. If you think about the motor symptoms, there's a parallel. Similar to the difficulty that Parkinson's experience with initiation of motor movements, there's difficulty in initiating goal-directed, purposeful behaviors. And these are at a higher level, okay? It also seems to be associated with different anatomical systems, more midline frontal systems. What about the treatment for apathy? There's been a lot less in this area. Some case reports, mostly of dopaminergic and other agonists, but there have been no psychological interventions to date. There is a type of therapy called behavior activation therapy. So, for example, in Parkinson's patients, if you put a line in front of them, it's a lot easier for them to initiate that movement. Or a metronome. So these external cues are helpful in generating motor movements. So let me just make a couple of concluding comments. To get benefits, you need to make the investment in yourself. What cognitive distortions are you most likely to use? Pay attention to those automatic thoughts that get triggered by upsetting events. What are they? You might want to keep a diary or a list of upsetting events throughout the day. What automatic thoughts do they trigger, and what cognitive distortions might you have? In terms of motivation, behavioral activation is all about planning and creating the steps to realize those plans. I have a shameless plug. We do have a Parkinson's active living program, which is geared towards symptoms of apathy. Now, the great thing about behavioral activation therapy is that behavioral activation therapy is also effective for depression. Now, we're really interested in looking at apathy because no one has done any kind of behavioral intervention for that symptom. So if you're interested, there is a flyer in your bag for contact information. It's a very structured, time-limited, telephone-based program. You can either get information by mailing us at the Gmail address or by phone. And I'm just going to leave you with what's in your toolkit. All right. That's it, and we hope to hear from some of you.